Our concluding speaker in this session is Dr. Howard Kadish. Dr. Kadish was born in Los Angeles, did undergraduate education at Tulane University, medical school at University of California, Davis, his residency at the University of California, San Diego, a fellowship at the University of Utah. These people, it's a magnet here, isn't it? He also has an MBA from the University of Utah and is currently division chief in the Division of Pediatric Emergency Medicine at Primary Children's Medical Center in Salt Lake. He teaches an undergraduate course on healthcare in America as well. He'll speak to us about head injuries, to scan or not to scan. Dr. Kadish.
Thank you very much. So a couple of weeks ago, I was going to go to Santa Cruz, California, and give this lecture. We're in the airport with my wife. We're looking for a really nice romantic weekend. Kids are away. And I get this phone call. Dr. Kadish, where are you? This is Santa Cruz. We're expecting your lecture in 15 minutes. I thought the lecture was on Saturday. It was Friday, and I was still in the airport. So I just want to tell you how excited I am to be here on time at the same day speaking to you guys. So I'm going to talk a little bit about head injuries. Of course, no financial relationships. If anyone has any questions or if they'd like articles that I've cited, this is my email address, and I am more than happy to shoot you copies of any of the articles that I reference in this talk. What we're going to talk today about is head trauma. I'm going to talk a little bit about evaluation, primary, secondary injuries, disposition, and then we'll talk a little bit about sports-related concussions. I'll spend a minimal amount of time of actual treatment of the severe head injuries, but we'll mention a little bit about what I feel is the most important aspect of treating patients with severe head trauma. Well, let's first start out, because I think this is what the big million-dollar question, this is what we do a lot of research on, and that is who to scan. Is it this guy? Is it that one? Is it that guy? I think it's personally him. He I definitely would scan. But that's the question that we argue about in emergency rooms and in offices all the time. Which are the patients that we should do the CT scan on? So, question for the audience. What is the most predictive of intracranial injury? Vomiting. Got to see a show of hands. Okay. Loss of consciousness? Hands. Okay, a little bit more. Immediate or impact seizure? No. Headache? Skull fracture. Okay. So the answer is skull fracture, all right? And this is what we always sort of have to kind of figure out, is when we're seeing these patients in our offices or in the emergency room, and you have a child that has an injury and then they have a symptom. They may be vomiting, or they have a historical fact. They've lost consciousness, or they may be amnestic. And we try to say, does this symptom carry increased risk of intracranial pathology? That's really what we want to figure out, if the symptom does or doesn't. Two really good studies that I hang my hat on. This one is out of England. It's a multi-center study in England. All patients seen in an ED with a head injury. 22,000 patients. So again, what they do on this is they first set up a criteria of patients. Let's set up an algorithm or rule of patients that we consider to have would be historical physical exam findings are significant for head injuries. So mechanism, high-speed road accidents, fall, high-speed injuries from projectile or object. If you have this history, loss of consciousness greater than 5 minutes, and this is important, greater than 5 minutes, because we all get those patients that have a brief loss of consciousness. I blacked out. I saw stars. I don't know what that really means. This is loss of consciousness for 5 minutes. History of amnesia, antegrade or retrograde, abnormal drowsiness, vomiting. They even tried to categorize how much vomiting. 3, greater than 3. Suspicion of non-accidental trauma or seizure after head injury. Okay. Physical exam findings. If GCS less than 14, penetrating depressed skull fracture, focal neurological exam, signs of basilar skull fracture, which I'll talk about in a second, or bruise or swelling or laceration, they consider these very high-risk physical exam findings. Basilar skull fracture. Basilar skull fracture, physical exam finding, you don't necessarily have to see it on a CT scan. Basilar skull fracture, we get the raccoon eyes, you can get the battle sign behind the ear, battle sign behind the ear, and then, of course, you can get some otorrhea. We did a study of primary children, and what we found was that in the well-appearing child, this isn't the child with base or skull fracture Glasgow 4, this is the well-appearing child who you look in the ear and you go, wow, you have a hemotympanum, or my gosh, you look like you have a battle sign. In even those patients, 20% had intracranial pathology. Now, not all of that was significant. Not all of that required neurosurgical intervention, but that was enough for us to say, base or skull fracture on clinical exam, you deserve a CT scan. Scalp abnormalities. What we have found is that the presence of a scalp abnormality is sensitive for associated skull fracture. And then I go back to that last slide where skull fracture is a prediction of intracranial pathology, and that has been shown. So when we see patients, usually less than 2 years of age, that have bogginess on their scalp, bogginess, a hematoma, a depression, which is consistent with or a possible skull fracture, then that certainly indicates to scan that patient. Now, what we're talking about is scalp. I'm not talking about forehead. So all of us with children who have had your 1-month-old running around who takes that digger and has that big hematoma right here on the forehead, that's not what I'm talking about. It's up here. And usually for us, it's the child who fell out of the shopping cart or who fell out of who fell out of a chair or a high chair. So let's go back to that study in England. What they found was, out of their 22,000 patients, if you did not have any of those high-risk mechanisms, history, or physical exam findings, then you had no significant head injury, except for 4 patients. So 4 out of 19,000. I think that's the most important take-home from this study. All right? If you did not have any of those high-risk mechanism, high-risk physical exam, high-risk history, then your risk of having intracranial pathology was extremely low. Negative predictive value, 99.9%. Now let's look at those 4 patients real quick. 2 patients had depressed skull fractures missed on exam. So really, they probably should have been scanned on the front end. So now I'm down to 2 patients, really, that the Chalice study missed. 1 patient returned 11 days later with a headache, small skull fracture, epidural found, did not require neurosurgical intervention, and 1 patient with no high-risk variables, okay, none, developed vomiting 2 hours later, subsequently scanned, found to have an epidural. And we're going to go back to this vomiting, what to do with these patients, and maybe we should observe them. And this is a great patient to talk about that. So for the Chalice study, I think it's pretty good data to say, hey, we can use this criteria, and we don't need to scan every single child. We can use some thought process with this. The next study is this PCARN study. PCARN is a pediatric emergency care research network, and this was a study we did. We were one of the nodes at our hospital. This is throughout the United States. This was a head injury study, over 40,000 patients, subsequently published in Lancet. Again, these are patients that have had head injuries, but, as you can see, not the standing, walking, running, just fell to the ground, otherwise looked well patients. All right? And again, prediction rule. What we came up with is a prediction rule and then we wanted to see how well that fit. Children less than 2 years of age, normal mental status, no scalp hematoma, except for the front. Remember, we talked about that. No loss of consciousness, non-severe head injury mechanism, no palpable skull fracture, acting normal. Pretty much just like the Chalice study. Results for the 2 years. Negative predictive value. So, what did we have? We had 1,000 patients in the less than 2 years of age. With them, there were no false negatives, 100% negative predictive value. Let's look at for children greater than 2 years of age. Greater than 2 years of age, once again, normal mental status, no loss of consciousness, no vomiting, and again, loss of consciousness, I'll go back to that, was that 5-minute loss of consciousness. No vomiting, no severe injury mechanism, no signs of base or skull fracture, no severe headache. Negative predictive value, once again, pretty good, 99.95%. So let me just show you. This is the flow diagram, and I just want to come here. This area, this here is for less than 2 years of age, and this one is for greater than 2 years of age. The point that I want to show here is that This area here, these are patients with Glasgow less than 14, abnormal neurological exams. That, I think everyone would say, that's easy. We'll just scan those patients, and no one's going to disagree. And those patients have a pretty high risk of intracranial pathology, okay, about 4%. These patients are the ones using the prediction rule. The children that otherwise looked well, no vomiting, no headache, no scalp abnormalities, and this number here is less than 1%. Less than 1%. So if you follow that, you'll miss less than 1% of children with intracranial injuries. Same thing here. This is for the 2. This is greater than 2. Same thing. These are the ones, okay, fine, Glasgow less than 14, abnormal neurological exam. These patients have an increased risk. These patients, no vomiting, no lethargy, normal neurological exam. These patients, again, have a 0.9% risk. Okay? Questions? So, let's now talk about what we should do. Let's get into the practical nature of it. Again, this patient population is easy, and I don't think anyone's going to argue about this. You've got after a head injury, you've got a depressed mental status, you've got focal neurological findings, you've got signs of the depressor base or skull fracture, acute skull fracture, we talked about how that is predictive of intracranial pathology, bulging fontanelle, children with physical exam findings of a skull fracture, bogginess on the scalp, witness loss of consciousness greater than 5 minutes, history of amnesia, antegrade, retrograde greater than 5 minutes duration. Most people would say scan those patients. I don't think there's much argument in the literature with that patient population. These patients. Again, I think these patients are pretty simple. These are the ones that you may or may not see in your office or in your ED all the time. This is the 1-year-old who takes the digger, has the big hematoma on the forehead, otherwise looks well, running around the room, tearing up your exam room. You don't need to scan that patient. Okay? It's these patients that we debate all the time, and this is what those studies are trying to get at. The vomiting, the transient loss of consciousness, the impact seizures, the history of lethargy, irritability. Reality is that what happens is you have a normal exam on these patients. If you didn't have a normal exam, you'd scan them. So we have a normal exam, but you have something in the history or something in a symptom that is bothering you. What to do with those patients? The studies will say on these patients, you will miss less than 1%. Let's just call it 1% of a patient with these symptoms with intracranial pathology. Now, are you willing to miss that with close follow-up, or do we end up scanning all those patients? That's the decision that we have to make. Now, I would advocate to say observation. It's not out yet, but in the June issue of Pediatrics of this same multi-center study, what they've done is just scrubbed the data and looked at other variances. There will be an article by, again, Nate Cooperman, looking at the observation period. And if we observe these patients, and if we pick an arbitrary time, I'll pick 4 hours after the incident. That's totally made up. So just so you know, there's no data to say that a risk of a bleed is going to happen within 4 hours, and then after 4 hours, your risk of bleeding is much less or much greater. We don't know that data. But at 4 hours, you observe this patient, and the study that's going to come out in the June issue of Pediatrics is going to say that you will decrease the risk of missing intracranial pathology significantly by another 0.5%. So I would advocate that on these patients, we take the very non-invasive and say, let's just watch. And this is what I tell my residents. Oh, he's had vomiting or he has a headache. Let's watch her. Is she still vomiting after 2 or 3 hours? Does she still have a headache? How is she acting? Oh, repeat exam, perfectly normal. Headache is resolved. Vomiting is resolved. Fine, go home. Versus, you know what, we've watched her for 2 hours and she's still vomiting or she still has a headache. Fine, scan that patient. And now, using this criteria, you can decrease even more the patients that we're scanning. And that's what I would advocate. And I think the literature would support that. And I will bring up, I think the literature will support that. And for those that are concerned about the medical liability of that, I think that there are plenty of pioneers in the field that would support that, meaning that would be your expert witness to say, no, the standard of care was followed very appropriately. This is now my sort of soapbox to get on for quality improvement and the standardization of care. These are 7 hospitals within the Intermountain system. This is McKay-D right here. This is the percent of CT scans for pediatric patients 0 to 18 through the year 2009. Now, this is all CT scans, so abdominal, neck, head, though head was the majority of them. I haven't scrubbed the data to look at specifically heads just yet. But what I want to show you is that if you come into this hospital, if you come into this hospital, number 7, you are 3 times more likely to get a CT scan than hospital 1. If you come into this hospital, you're 2 times. Now, I don't know where the right ball should fall. I don't know if the answer is this right here or this right here. But I do know that you can't have all of this variation and say everyone is right. I don't believe that. And that's why I think it's extremely important that we try to look at how we best can standardize our care in the pediatric population, but I think in all medicine, and then, of course, evaluate it, look at it, and see if we're doing the right thing. But it just doesn't make any sense to me that we can have that much variation and everyone be right. This was a recent article that came out in Radiology. Some of you may have seen this, and this just shows that significant increase in CT scan. 5-fold increase with annual growth rate of 13.2%. I think we'd all love our stocks and all our mutual funds to be doing that well right now, right? CT scans at pediatric focused EDs. I don't want to just sort of make this like, oh, this is just adult EDs going wild with CT scans. This is a pediatric ED focused problem, 14,000 to 200,000, and then non-pediatric focused EDs, 300,000 to over 1 million. And interestingly, follow-up studies have shown we're not any better at picking out intracranial pathology. So it's not like we're saving lives by doing all these CT scans. Why not scan all patients? We've talked about this. Radiation is a big deal, and it's becoming bigger and bigger. And I believe, I don't know this for a fact, but my own belief is that 15, 20, 30 years, we may look back and we may see some complications from all the CT scans we're doing on our pediatric patients and go, I don't know if that was the best practice. We'll see. Location of CT scanners, depending upon where you practice, depending upon the location, can be difficult. There's a cost involved, and then there's sedation involved. I get asked all the time regarding sedation on patients, what should I use? Let me show you what I would recommend.
As a mom with 3 active kids, I've got to make sure I know what they're up to at all times. And as any mom will tell you, they can be a handful. That's why I give my kids Kidstone Chewable Valium.
Kidstone Chewable Valium, the barbiturate the whole family can enjoy.
And once the Kidstone Chewable Valiums kick in, these kids kind of stay right where you put them. They're quiet, relaxed. It's a dream. And just about all you have to do is check their breathing every once in a while or just poke at them with a stick.
Kidstone Chewable Valium, from the makers of nitrous oxide balloon animals.
Use it if you like. Okay, so we've covered to scan or not to scan and who to scan. And if after the lecture, I'm more than happy to talk to, and if you guys got questions, and I'll be around here for lunch, and I'd love to talk to you because it's a great controversial, gets people's blood boiling. Real quick on treating severe head injuries. I said I'm not going to spend too much time. There's the primary injury immediately caused by the trauma. There's ischemia. There's increased flow. There's increased neurodegeneration, and the cells become leaky. The bottom line, and this is where another soapbox I get on, is that there's nothing that we can do for this, right? For the primary injury. What we can do as healthcare providers is prevent the primary injury, and that's where I think it becomes important for us to be advocates regarding car seats, seat belts, helmets, for all of our pediatric patients, because we know that if this mom stops short, she can't do the Seinfeld grab, right? If you all remember that from the show, that's going to happen, okay? And then we've just failed this patient. So I really believe strongly that that's one of our roles in the healthcare is to try to advocate for our pediatric patients for these type of safety measures. Secondary injuries, what we want to do is we want to prevent secondary injuries. There's a whole host of them: hypoxemia, hypercarbia, hypertension, seizures. What I want to concentrate on is hypotension, because if you look at head injury data, and in fact, if you look at pediatric sepsis shock data, so head injury data, sepsis shock data, the number one marker for increased morbidity or mortality is untreated hypotension. And that's for patients with head injury, and that's for patients with sepsis and shock. This is a traumatic coma data bank that they do is they sort of take a look at all pediatric traumas coming through. But what they found was hypotension and hypoxemia are among the 5 most powerful predictors of outcome. So that's what, if we're going to be taking care of these patients in our trauma bays, in our emergency departments, that's what we need to really concentrate on. A single episode of hypotension was associated with a doubling of mortality and an increased morbidity, and it comes back to this equation. If you remember, cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. It used to be, we're all taught, decrease intracranial pressure. Let's hyperventilate these patients. Let's fluid restrict these patients, right? Let's decrease intracranial pressure. And what we're finding is that's wrong. What we really want to do is maximize the mean arterial pressure, not make these kids hypertensive. That's not what I'm talking about. But we want to normalize their blood pressures, because we can see if cerebral perfusion pressure increases, then the cerebral blood flow should increase. Okay? This is another study out of our institution by Dr. Zebrak. What they found was, in our resuscitations with pediatric patients in head injury, children who did not receive an attempt to treat hypotension, so these are children that were hypotensive, increased odds of deaths was 3.4. Increased odds of disability is 3.7. This is significant. So if I had to preach for those of us taking care of the acute patient in our trauma bays, that is, it's hypotension and hypoxemia we should be concentrating on. Absolutely, we need to get our neurosurgeons involved right away. Absolutely. But our initial management, of course, ABCs, airway, breathing, circulation. Simple as that. Now let's talk a little bit about the disposition of the head injured patient. So now you have someone who comes on in, and they may or may not have gotten the CT scan. They may have a skull fracture, a base or skull fracture. They may show signs and symptoms of a concussion, which we'll go over. And what are the patients that we need to admit to the hospital, watch, and what patients can we send home? These patients that I'm showing you up here, the skull fracture, the base or skull fracture, as we've talked about in our previous literature review, those patients we should have already scanned. And so assumption is these patients, skull fracture, base or skull fracture, have negative CTs. So I'm not talking about anyone that has an abnormal CT scan with intracranial pathology, unless you see the base or skull fracture. That makes sense to everyone? So let's take a look. Can patients with a skull fracture be safely sent home? When I was a nice little junior faculty at University of Utah and I had one of these patients, and I called our neurosurgeon who has been there for ages and ages and ages, he pointed his finger at me and I asked him, should I send this kid home? And he pointed his finger at me and he said, admit him. And then he walked away. That was my education. But in reality, we don't need to admit these patients. There's 6 studies out there combining 349 patients, incidence of clinical deterioration for children with an isolated skull fracture. One skull fracture, okay, isolated, and no intracranial pathology. Of course, also no concerns of non-accidental trauma or anything like that, was 0. So I think you can safely send these patients home as long as they have a car, as long as they have close follow-up, all those important things that we talk about. Can patients with a basilar skull fracture be safely discharged to home? Okay, I told you that basilar skull fractures, we should scan these patients, but let's say the scan's normal. We did an article at Primary Children, subsequent articles have followed up, 421 patients with basilar skull fracture with Glasgow 15, normal neurological exam, normal head C except for basilar skull fracture, no cases of delayed intracranial pressure, intracranial hemorrhage. So again, I would say these patients can be safely sent home. Again, with the big asterisk, got to have close follow-up, got to live close to a medical community. If I have a child that I'm seeing that lives in Wendover, no, I'm going to probably admit that child. But if I have a child that lives within the Salt Lake Valley that has health care, has a car, has an understanding family, I will routinely send home those patients. Can patients with a concussion be safely discharged home? We'll go over in second definition of concussion. 3 studies, 1,700 patients, all patients, again, looked well, Glasgow greater than 13, normal neurological exams. These patients all had normal head CTs, no cases of delayed intracranial hemorrhage. So, again, a patient with concussion in your emergency department, in your office, you can also safely discharge them home. Again, reference, big asterisk, got to have follow-up, got to live close by. What I'm really talking about is CT scan or even observation as a triage tool. What you're doing is you're saying, I've seen you, I've observed you, or I've scanned you, and it's normal. I've triaged you into having no intracranial, and now you can go home. And that's very appropriate. This is a patient sent to us from an outside institution. This is a normal head CT. This is a head CT about 6 hours later when she developed symptoms. This is the epidural right there. So cases of delayed intracranial bleeds do happen. We know that. But how often do they happen? Hard to get at that number. Looking at the studies I just cited, pretty rare. And again, as long as we have good close follow-up, as long as we educate, as long as we make sure that the families know what to look for, there's a subset of patients that we can safely discharge to home. Discharge criteria, this is what I use, this is what we recommend in our emergency department. Of course, no intracranial injuries, normal neurological exam, no suspicion of abuse or neglect, reliable caretakers, simple skull fracture, I define that as one single fracture. Little controversial, as you start getting into the younger kids, we all feel a little more uncomfortable with, sometimes difficult to figure out. Are they irritable? Are they not irritable? What's going on with them? So some people would say less than 3 months, less than 6 months. We may want to watch them overnight. I routinely will use 3 months. Some of my colleagues will use 6 months. Base or skull fracture, and of course, symptoms are not getting worse. If you have a patient that you've seen that has a concussion, you scan them because they're persistently vomiting, and they're continually vomiting, I'd probably say that patient should be admitted. Not because I'm really worried about for increased intracranial bleed, but that they need IV fluids, they need treatment, and what are you going to tell the family to come back for? Persistent vomiting. Or if they have a really bad headache and you haven't helped out the headache, come back for persistent headache. So it makes it difficult to discharge those patients. So again, symptoms aren't getting worse, they're getting better. All right, now let's move into concussions. For any of you all that have children or have boys, I have some teenage boys, and I consider them sort of one big cavity with one big neuron. I swear to God, someone has sucked out my son's frontal lobe. Just boom, right out there. I know you all have experience with this. I want to share this with you because I'm an advocate of World Wrestling Federation. I don't think so.
Not just brother against brother. Come on. Yeah, it is. And look at Lewinsky. Get either one of them, Chris. Turn around. Lewinsky thought he had eliminated both. And Rey Mysterio. Turn around. You didn't get either one of them.
So it was right at that moment, and that was Chris Nowinski. Chris Nowinski is best known. He was a football player at Harvard. He became a World Wrestling Federation. He was known as Chris Harvard. That was where he sustained his head injury concussion, which subsequently put him on the path to developing what's called the Sports Legacy Institute. And it's him, along with some other physicians, that started the institute that started to look at the brains of NFL players post-mortem and started to find this finding. This, of course, is a normal, and then what they were seeing is these plaques that had developed post-mortem, and they had subsequently come out with what is now described as the chronic traumatic encephalopathy. And that's what has gotten so much press and so much publicity recently because of that. But that's what sort of started him down the road of the head injuries. So we know concussions are a big deal, and we're becoming more and more sensitive to our younger athletes, our football players, our lacrosse players, our soccer players, or anyone that's doing any sports that is sustaining multiple concussions. And the question, of course, is how do we define a concussion? Because that's the first important thing. Because now the consequences of developing a concussion are pretty significant. I mean, significant from everything from you're out of the game. And let me tell you, when I pulled my son out of a game, who plays football, for a concussion, and I just got berated by the coach. And my son's not that good of a player by pulling him out. So it's a big deal to not any sports for a week, no sports for a year. It's a big deal when you start diagnosing people with concussions. This was a pretty good article out of PEDS, sort of tries to get at and define what a concussion is. Caused by a direct blow to the head, face, neck, elsewhere of the body with impulsive force transmitted to the head. Rapid onset of short-lived impairment of neurological function that resolves spontaneously, results in a graded set of clinical syndromes that may or may not involve loss of consciousness, associated with grossly normal structure of neural imaging. Still kind of difficult to get your arms around that when you're on the field and someone says, hey, doc, would you mind looking at this kid? He just got hit in the head and now he's complaining of a headache. Does he have a concussion? That's a tough one. Because if you do say yes, it means it's significant. We know that it's certainly significant out there. These are some of the numbers. I think these numbers, and everyone thinks these numbers are higher just because concussions are occurring and they're not being seen by their primary care physicians or they're not being reported. So this is how I kind of think about concussions and how I try to think about it in the physical standpoint, cognitive, emotional, and sleep. And some of these occur right away, and some of these will occur 2 days afterwards or 3 days afterwards. And so we have to be aware of them. So physical-wise, headache, nausea, vomiting, balance problems, visual, fatigue. Cognitive, mentally foggy, slowed down, difficulty concentrating. You'll get this sometimes from families or from even the patient themselves saying it's hard for me to do well in school. It's hard for me to concentrate. Irritability, sadness, really emotional lability. Sleep, drowsiness, sleeping more than usual. Again, I got to go back to the teenage boy. My kid sleeps till like 3 in the afternoon. I think that he's got a concussion chronically. All right. Difficulty falling asleep. Oh, that would be my son too. Okay. But these are the things that I try to look at and say, do you have these aspects and do you fall into the concussion mode? On the field assessment. All of us, if we're involved with any type of sports and people know that you're a physician, will say, hey, doc, would you mind helping out? Or maybe you all do are the sports physician for a team or such. You will be asked, hey, doc, will you go take a look at this kid? This is what I do, and I try to do it on every child. ABCs, of course, cervical spine, neurological evaluation, neurological, motor, sensory, Glasgow, that type of thing. But then I get them off the field, and then I start asking them some questions to test recent memory. What's the name of your team? What team are you playing? Simple things like that. Ability to perform simple tasks. Repeat these numbers after me. 5, 4, 3. 5, 4, 3. Repeat these numbers backwards. And so that's what I'll do, just a couple of. And then stability. I will have them hold their arms out, one leg up, one leg down. A very quick, down and dirty sort of exam. If I have a child that gets hit that has a relatively minor mechanism of injury, that has a relatively minor symptom, I have a little bit of a headache, but I'm all better, and I go through all these things and they look fine, I'm not willing to say at that point that child has a concussion. Certainly if that child starts developing other symptoms with time, then we may have to readdress that. Management. I think each concussion should be managed individually by using multiple means of assessment. There are huge assessment tools out there, everything from, and I will show you a reference, everything from standardized, computerized tests that we can pre-test all our athletes, and so when they have a concussion, we can use that same test and see how they're doing. I highly recommend those for either athletes or individuals that have had previous concussions or that are in high-risk activities like football. Or there's just standardized forms that you can put patients through in your office to look for a concussion and questionnaires. No player should be returned to play until the symptoms of concussion have resolved completely, both at rest and during exercise. And I think that's also what we've learned, that it's the repeated concussions that get these patients into problems, that if they have symptoms, and Chris Nowinski talks about how he had developed the concussion and he continued to wrestle afterwards, and things just got worse and worse and worse. He had headaches, he had emotional irritability, he was having memory problems, and he continued to wrestle, and those symptoms just got worse and worse. This is what I recommend, and this is what we try to standardize in a sort of, I use it as a 6 or 7 step sort of process. So, you have a patient that you think does have a concussion. Then we start off with no activity, complete physical and cognitive rest. They're out. They're down. They're resting. And I do this one day at a time. This is it, just one day at a time. The next day, as long as they don't have any symptoms, they can do light aerobic activity. Walking, swimming, stationary cycling. They can go back to school. Now, as long as they don't have any symptoms. Now remember, I keep saying this. So if they have symptoms, now we started this and they're starting to have headaches again, or they're starting to be having difficulty concentrating. Then I go back to step 1. Then I go right back to ground zero. Okay? Specific sport exercises, specific sport-related drills, but no head impact. So they can play football, but they're not doing contact drills. They may be just catching and passing. They can do lacrosse, but they're not doing any competitive. They can just throw and catch. Non-contact training drills, more complex drills, but may start light resistance training. Full contact practice after medical clearance, participate in normal training, and return to play normal game day. And if you do this, this comes out to be about a week. And that's what most people recommend as time off from a concussion. People will say 7 to 10 days. So, and that's usually what I recommend and what I try to get families to buy in on with respect to treating patients with concussions. Again, I go back to, I do think it's important that we start to standardize how we're going to manage these patients. Because you can imagine how confusing it is from a family if I say, here's my plan, we're going to do X, Y, and Z, and then they go see another physician, or they go to their primary care physician and follow up who says, no, we're going to do this. Now again, you can debate who's right or who's wrong. I sometimes don't know that. But I do feel that it's important that we try to get to the bottom line is the right answer and start to standardize our approach. Otherwise, we'll never get to the right answer, and it just confuses families. Well, how come he said this but she said that? Here's some testing. Here's some neuropsychological testing. There's the automated neuropsychological assessment metrics. There's head mining. There's impact. These are all fees, so you have to pay for these type of testing. These are much more intricate. Then there's the Sports Concussion Assessment Tool, what's called the SCAT, or Standardized Assessment of Concussions. These are something that you can do in your office. This is just usually filled out by paper, having them do a questionnaire. You can do this pre. So if you're seeing a child for sports physical, you can have them do these. And then if they have a concussion when they come back in, you can once again do these assessment tools. This is the 2010 AEP is a clinical report on sports-related concussions. They have these forms in there, and they have a lot of the references that I've just referenced. So very good article. And finally, want to talk about House Bill 204. Are you all aware of this House Bill? This is now law. Players, it's a relatively, there's more to the law than this, but I pulled out what I felt was pretty significant. Early on, families, if you're going to participate in athletics, have to sign this form stating that you know the risk of concussions. Players cannot return to the game if you have a concussion. So that's why it is significant. If you say you have a concussion, then that player is out for the game. Must receive initial evaluation by a healthcare provider. Must receive. It's in the law. So again, you can imagine what are the financial aspects of that to a family if you say you have to now go see your healthcare provider. And must receive clearance to play from a healthcare provider with experience in concussions. They go in the bill about what does that mean, experience with concussions for your healthcare providers. You have to have X amount of CME type credit. But this is a law now. So for all of us that are taking care of pediatric patients, primary care in the emergency department, you may be asked about this, or you may be having families saying, can my boy come back? So I suggest at least you come up with a game plan of how you're going to evaluate, treat, clinically clear, or refer these patients. And finally, I just wanted to mention, I did not talk about non-accidental trauma or shaken baby syndrome, but I did want to bring up one of my sort of concerns, which I call is the shaken man-child syndrome.
This is the Onion News Network. Better news, better viewers.
When I saw his teeth marks in the block of cheese in the refrigerator, lost control.
Did you know shaken man-child syndrome is the second leading cause of death among adult children after choking on buffalo wings? Hi, I'm Ben Stiller. As the star of movies like Zoolander and Dodgeball, many of my biggest fans are man-children. Every year I travel to hospitals to meet some who have survived abuse, and I'm always inspired by their bravery. Even through their injuries, most find the strength to quote one of my lines from Along Came Polly or give me a fist pound. It's a personal issue to me, because until I was almost 42, I was a man-child. I had a cat that I ironically named Dog. I would put ketchup on my rice and noodles. And the only art object I owned was a replica of Mr. Spock's Vulcan harp. Was it frustrating for my parents? Of course. But they knew you should never, ever shake a man-child, no matter how angry you get.
Just because I don't have a life doesn't mean I don't deserve to live.
Questions? Thank you, guys. So the question was, is if a skull fracture is a very good predictor of intracranial pathology, is there a role for skull x-rays on an outpatient basis? And I would say absolutely yes. A couple caveats with that. And that is, one, I find myself personally skull x-rays are extremely difficult to read, very confusing, and especially in the younger child, right, of course, because with that. And for us, the prediction of the scalp abnormalities, if you look at some of the data, they'll talk about 70%, 80%. So I would advocate that, yes, certainly you can use that as another branch point, totally appropriate. But if you're going to get them, I suggest you get them in the setting that you feel comfortable someone's reading them. I'll be honest with you, I don't feel myself comfortable reading them. They're very difficult for me. But it's a good question. So the question was, the old adage was, wake the child up every couple of hours after a head injury and check on how they're doing. So I'm not sexist. I'll just call that an old wives' or husband tale. But the answer is yes. We don't do that anymore. We don't recommend that anymore. All you really find is that you just have an irritable, fussy child who says, why are you waking me up? So no, we do not recommend that you need to wake these patients up that you send home. So the question was, is the huge variation in the CT scans of the Intermountain hospitals. And the question was, was the lowest one primary children's, other one in a rural place. So one, all of them are within Salt Lake County. So, McCady, Utah Valley, IMC, Riverton, and then also primary children's. Yes, primary children's was on the other end. So we were the lowest as far as obtaining CT scans. That you could debate many ways. You could say, well, we're a major referral center, and so we're getting patients already scanned that are referred to us, so that's why we didn't need to do those scans. You could also then say, though, we are the major trauma center, 14 and under, And so we're getting patients that are coming straight to us that we are scanning those. The answer for that is I don't know. We have to scrub that data a little bit better. But even if I took out primary children's, you still have a wide variation between McCady, IMC, Riverton, Utah Valley, American Fork, and there was one other one that I think I had in there. Any other questions? As always, it's a privilege to speak to you guys. Thank you so much. How'd I do?
Thank you. You did perfect. I would like to thank Dr. Kadish and all those who participated today. Lunch will be served at noon, I believe, in Ballroom A. That's where we met this morning, first of all, just around the corner. So if you'll reconvene in there to hear Dr. Tubbs speak on prison medicine. I'm told it's very interesting, and in fact will probably include a whole lot of stuff you would really rather not know about.